Welcome to You and Your Health. I'm your host, Dr. David Bertone. Today we're going to talk about common eye diseases and some typical or frequently used surgical procedures for these diseases. Our guest today is Dr. Revathi Naadimuthu. Dr. Naadi, as she is known as, is a fellowship-trained, board-certified ophthalmologist, and her practice is located in Freehold Ophthalmology with locations in Freehold, Toms River, and Bricktown, correct? Mm-hmm. Dr. Naadi, welcome to the show.
Hi, thank you.
So we're going to talk about common eye diseases. Tell us a little bit about your background and how you got involved in ophthalmology and chose that career path.
Sure. I'm a Jersey girl, born and raised. So my mother is a doctor, my father is a professor, and I think most of my life I knew I wanted to be a physician. And I went to Rutgers, then I followed at Robert Wood Johnson, which is now Rutgers Medical School, for medical school. Then I went up to New York and did my residency in ophthalmology, then fellowship in Texas in cornea.
Awesome. And then you started the practice in Freehold Ophthalmology?
Yes, in 2009.
Wonderful. So we're going to talk about some of the common diseases, and the one I'm sure you get the most questions about is cataracts.
Absolutely.
And what, maybe just start basically, what is a cataract, and maybe explain with some of the models that you have, and how do you go about diagnosing that problem?
Sure. So cataract is the lens that's in your eye. So the lens that we're born with sits inside the eye, behind the cornea, behind the iris. The lens is clear and soft when we're born. As we get older, it starts to harden and stiffen up. Okay. Usually around the age of 40, we start noticing the need to use reading glasses for up close. That's part of the stiffening process with the lens. As we age still, the lens starts developing some cloudiness to it. So whereas it's clear when we're young, as we get older, we'll start developing some opacities. So then it blocks the light that enters through the cornea, through the pupil, and the light ends up getting scattered and not reaching the retina properly. So one of the first steps in diagnosing cataracts is really when a patient comes into the office, they will tell me, you know, doc, I'm having a little more difficulty seeing street signs. I'm not really having as easy of a time reading my books, even if I use stronger and stronger glasses. So then when I take a look at the exam using my slit lamp, which is a special microscope, I'm able to take a very close and in-depth look at the eye and all the structures, and I'm able to see, yes, in fact, there is a clouding that's developing in the lens.
So that particular microscope, it's just to see the cornea, or you see other stuff when
So that slit lamp we use to diagnose almost everything in the eye. Okay. It's a special lamp that allows us to see the structures from the front of the eye to the back of the eye. We'll use special lenses to focus the light onto different structures. So we're able to see the cornea, the iris, the lens, the vitreous, which is the jelly inside the eye, and the retina.
So what is the most common age that people will start noticing this?
So the average age for cataract surgery is probably around 80.
Wow.
But there are a lot of my patients who are in their 60s, and I've even had to do surgery in very young patients in their 30s. They've just developed cataracts early on. Sometimes, most of them will be age-related, but sometimes if there's been a history of trauma, like a baseball that hit someone even when they were 10 years old, that can make you more prone to developing a cataract early on.
Are there other diseases that could cause this process, things like diabetes and
Diabetes,
such?
We do tend to see cataracts diagnosed a little more early in life.
Okay.
As I said, trauma, certain medications like steroids, prednisone can cause, we've been seeing cataracts develop relating to that as well.
Now, are there any other treatment options besides surgery? Is there any drops or other procedures before you have to replace the lens?
Unfortunately, no.
Okay.
A lot of it has to do with genetics. I've seen 80-year-olds that have a perfectly clear lens. So that's certainly related to genetics. Also sun protection. By the time we, or UV protection, by the time we see cataracts, the UV light has already done what it's going to do. So there's not really anything that we can do for that. There are things on the horizon that are being developed to see about possibly dissolving or even preventing cataracts. But right now, there's not too much aside from surgery.
So besides the genetics, it sounds like the sun is a big cause. So proper sunglass protection is really critical early on. So now let's talk about the surgical procedure. So what's involved when you do cataract surgery?
So the surgery is performed as an outpatient procedure, which means they can go home the same day. 99% are done at a surgery center. So the procedure itself takes about 15 minutes.
Wow.
It's done under sedation so that the patient is comfortable. They usually will get an IV. We'll make them nice and sleepy. Then we use numbing drops to numb the eye. We do one eye at a time. So we'll do one eye, and then a couple weeks later, we'll do the second eye.
Okay.
Now, there are two different ways, main ways that we do cataract surgery. The standard surgery, we make a very small incision on the side of the cornea. We call that a clear corneal incision. We go in with a probe. The probe will break up the cataract using ultrasound energy.
Oh, okay.
Then that same probe has a vacuum function as well. We can remove all those broken up pieces of cataract. Then we're left with an empty capsule. And within that capsule is where the new lens implant will sit. So the lens implant, this is a model of a lens implant. It's actually just the yellow part. This is in a capsule, not anatomic. The lens implant actually folds up so that we can place it in through that very small incision, and then it opens up in the eye. Most of the time, we don't even need to put a single stitch in the eye. To give you an idea, this is actually a model. This is actually the size of a lens implant.
Wow. That's
the actual size of it. This one has a blue blocking filter, so you can see it's a little bit of a yellow tint.
What would be the purpose of that, the tinting?
So that's actually a controversial topic because one is to protect the macula against harmful UV rays for things like macular degeneration. But there have been certain studies that have shown that blue blocking can sometimes increase risk of depression because you're blocking some of the blue light, which is important if you're familiar with phototherapy for some people who might be depressed seasonally. Yeah, so we'll use both blue blocking and non-blue blocking lenses.
Now, so it sounds like you use this probe and you get the old lens out. Is that a difficult process, or it just dissolves and comes right out?
So the whole cataract surgery takes about 15 minutes.
Wow.
So the breaking up of the cataract is just a couple minutes long. Now, there's a second procedure, which is somewhat newer. It's maybe been around for about 10 years, and it's called femtosecond assisted cataract surgery. This is, in other words, laser-assisted cataract surgery. With laser-assisted cataract surgery, the laser makes all the incisions. The laser softens the cataract using air bubbles. It's a little more gentle to the eye. The outcomes tend to be more precise because a laser is performing it. We, as surgeons, still have to go in and remove those softened pieces. We still, with a vacuum, we still have to insert the lens into the eye. So there's still a portion that we're still doing, but it's assisted greatly by the laser.
Got it. Now, it sounds like you have to make this incision. You do that manually?
Yes, yes.
So this might be a silly question, but how do you keep the eye still? Is that just because it's numb?
So we do use a speculum that holds the lids open. So that's a good question because people are concerned they might squeeze shut.
Yeah.
And then we're usually able, they're sleepy, so It's not as difficult as it sounds.
Okay.
We used to actually, in my training, we would give an injection called a retrobulbar injection, which would block the nerve, and
okay.
that would stop all movement.
Got it.
But then they would have to go home with a patch and shield on the eye because it paralyzed the muscles temporarily. They wouldn't be able to remove it until the next day.
Yeah,
Being
I
that the
remember
procedure luckily is about 15 minutes long, we're able to manage in that short period of time, and then most will leave with a clear shield over the eye that they can remove when they get home.
So that brings us to the recovery. So how long does it typically take for somebody then to see clear, and is there any preventative steps they have to take after the surgery?
Sure. The surgery, definitely we do not want them to do any heavy lifting. We don't want them to wash their hair for 3 days, which can sometimes we get a little pushback on. We don't want them to wet the face for about 3 days. Now, the recovery, depending on how dense the cataract is, some patients by the next day they're seeing so clear. Other people, it will take a couple of weeks for the vision to improve.
Okay.
So it's on a range, and usually as a surgeon, we can predict many people whether or not they'll be in the category of seeing well by the next day versus taking a little bit longer.
Now, because it's just the lens, and it's cloudy, does it change their actual, their prescription? Say if they wear glasses, can you change that?
Absolutely.
Okay.
Now, one of the great advances with cataract surgery is the lens implants. The lens implants come in different powers. We take extensive measurements to determine the lens power that will go in the eye. There are also lens options that are advanced technology lens options. These lens options may include a toric lens implant. A toric lens implant corrects for astigmatism. There are also multifocal or extended depth of focus lens implants that allow you to see clearly in the distance and up close as well.
But obviously you can't change that as frequently as you would glasses. So if that
that's not a permanent solution.
So if that's not corrective, say in 3 or 4 years, then you would have to correct it another way externally. You wouldn't change the lens, correct?
Most of your prescription is established by a certain age, usually in your mid-20s. And a lot of that does have to do with the size and length of the eye, but also the lens. As we age, then if there are any changes to the prescription, it's likely related to the lens or the cataract. So once we remove the cataract, the lens implant that we put in your eye should be your prescription for the rest of your life.
Oh, okay.
So yes, if someone who's very nearsighted, we can correct them to be seen clearly in the distance, and then that will last the rest of their life.
And there are multifocal options, so you can you have reading and distance capabilities?
Mm-hmm.
Oh, interesting. Is there any contraindications? Are there any patients where it's not appropriate, cataract surgery?
Not usually. Sometimes with certain conditions like diabetes or macular degeneration, if there's uncontrolled diabetic retinopathy or very active wet macular degeneration, we would like for that to be controlled and kind of quieted down before we would actually go forward with the cataract surgery. But there are many conditions involving the retina where the retina doctors will ask us to perform this cataract surgery first so that they can have a clearer view when they're performing retinal surgery.
Great. Okay, so when we come back, we're going to hear more about various eye diseases and the surgical procedures available to correct them.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today our guest is Dr. Revathi Naadimuthu. Dr. Naadi is a board-certified ophthalmologist with offices in Freehold, Brick, and Toms River. And we're here talking about various eye diseases and surgical interventions. Dr. Naadi, thank you for coming.
Thank you.
So we talked about cataracts. During the break, we were talking about the drop schedule.
Yes.
Can you just get into
Cannot
that
forget about the drop
so people understand
schedule,
what
yes.
the drop schedule is?
So one thing that I definitely did not mention is that usually before surgery, we'll start some eye drops 3 days prior. These drops are an antibiotic drop and a steroid drop just to help prep the eye. After surgery, there are 3 different eye drops. One's an antibiotic again, a steroid, and then a non-steroidal, similar to like an Advil or ibuprofen, except in eye drop form. These drops will last over a 3 to 4 week period of time. The first week, you'll be the most active using the eye drops, and then they taper.
Okay. So it's there to prevent any
infection, prevent inflammation.
Things like that. Okay, great. So let's talk about some corrective procedures. Laser vision correction is very popular.
Absolutely.
There, I guess, is a term called LASIK. And can you explain what that is and how it works?
Sure. So the 2 most popular refractive surgeries are LASIK and PRK. LASIK is a procedure, both of these procedures are performed on the cornea, which is the front clear part of the eye. LASIK is a procedure where we will cut a flap and we lift the flap, similar to peeling the skin of an onion. That flap is cut using a procedure called the intralase. The intralase allows us to make this surgery completely bladeless. About 10, 15 years ago, we used to use an actual blade to cut that flap, and some of the issues then, in terms of complications, were almost all related to the blade. Okay. So bladeless has eliminated many of those complications. Once we lift the flap, then a second laser is used to perform the treatment in what's called the stromal bed. That's the center part of the cornea. That takes about, all said and done, it takes about a minute for the intralase to cut the flap, about a minute and a half for the treatment, and then the flap is laid back down and the procedure is repeated for the other eye.
Okay.
Not everyone is a candidate for LASIK, in which case we'll choose to perform PRK. PRK actually existed before LASIK, and PRK is a treatment that is pretty much done right on the surface of the cornea. First, we prep the surface of the cornea by just very gently scraping the surface cells. Then the laser is performed for about a minute and a half, and then usually we'll put something called a bandage contact lens, which is a clear contact lens, right on the surface of the eye. The upside with PRK is that some patients who aren't candidates for LASIK will be candidates for PRK. And the outcomes are exactly the same. If you look 3 months down the road, the vision is exactly the same between LASIK and PRK. PRK, however, it takes longer to heal. You're a bit uncomfortable for the first several days following the procedure, but those cells do grow back, and as I said, 3 months out, the recovery is the same. Okay.
So you're typically using this for somebody that's nearsighted or farsighted? Does it matter?
We can do both.
Okay.
We can treat both nearsightedness and farsightedness. One of the downsides is, though, as we discussed earlier in the program, around the age of 40, we start needing to use reading glasses for up close. LASIK and PRK can treat for what's called presbyopia, not being able to see up close anymore. But we would have to use something like monovision, where we correct one eye for distance and the other eye we correct more for up close or near. Okay. There's not a great treatment available in the US yet that allows you to treat both eyes for distance and near at the same time.
Now, how long does this procedure last? In other words, if you have it done in your 30s, in 10 years, your vision might be different. What happens then?
So 90% of people it lasts the rest of their life.
Okay.
Now, in your example, if you get it at the age of 30, by the time you're 40, so let's say you were nearsighted and you needed to wear glasses for distance, but your vision up close was fine. When we correct you for the distance, and once you turn 40 and reach that age of presbyopia, you'll just need to start wearing reading glasses.
Okay.
So your distance vision will still maintain that correction, but you'll just need to use reading glasses for up close.
Okay. Are there any complications of those procedures? Is there risks of infection or something going wrong, or how does that work?
Sure. All surgeries have risks. Risk of infection, risk for needing more than one procedure. It is incredibly rare to lose any vision.
Okay.
I would say infection is probably the if we're going to use the word common, would be the most common, but that is still extremely rare, again, because there is a drop regimen that we use, an antibiotic drop and a mild steroid, and these greatly reduce those risks. Also, those risks of what we would call flap complications in LASIK. The flap complications were mainly related to using a blade to cut the flap. Since we don't use a blade anymore, the laser is more precise to cut the flap, and it's bladeless LASIK, so we virtually eliminated those blade or flap related complications.
Got it. Now this has been around for a while, and it used to be very expensive. Has the cost come down over the years, or?
I would say no,
Okay.
because as similar to computer technology, and televisions, for instance, there's always newer and newer technology that's coming out. So 20 years ago, we didn't have some of the custom technology and the wavefront technology that we have now. So as time has passed, technology has advanced, and it basically means it's
have to
still
pay for
pretty
those.
expensive.
Yeah.
Well, it's, we always have options that help finance it.
Okay.
So,
But it is an elective corrective procedure. It's not
Yes.
usually covered by insurance, correct? The
they're not
LASIK?
usually covered by
Yep.
insurance.
Okay, so we're going to move on to glaucoma.
Sure.
There's also another big eye disease. What is the method that you use to diagnose it, and what is glaucoma, and how do you treat it?
So glaucoma is a disease basically of the optic nerve. So the optic nerve is in the back of the eye here. It's basically like the power cord that attaches to the back of your eye, and it travels around to the back of your brain. The main way that we screen for glaucoma is by checking pressure. So many people will be familiar with the puff of air test. Generally in our office we don't do that puff of air, but it's a different test that we use to measure the pressure in the eye. The eye, if you think of like a balloon, you want it to have a moderate pressure, and the pressure that we measure is in millimeters mercury, between around 6 and 22. If you fall higher than that 22 range, that is something that then we need to perform other tests to determine whether or not you're at risk for glaucoma. Some people can have glaucoma and still fall within that normal range of pressure. The problem with the pressure in the eye is it affects the optic nerve, causes damage to the optic nerve. The problem with glaucoma is that it tends to affect vision from the periphery in. So it's not as simple as cataracts and macular degeneration, which affect the central vision. People won't notice damage due to glaucoma because it's coming from the outside in. So the only time it would be noticeable is if it is very, very severe.
So it's something that's picked up usually on an annual exam, maybe
Sure.
the pressure may be off.
Absolutely.
But if somebody is not going for their annual exam, they might start noticing some peripheral difference or just like a tunnel vision, right? So they're
Right.
just seeing what's straight ahead.
And the dangerous thing with glaucoma is that because it's nerve damage, the goal of treatment is early detection and prevention. Because once there's been damage to the optic nerve, you cannot reverse it. So anyone who has a family history of glaucoma should make sure that they get in to see their eye doctor.
So the treatment is to reduce the pressure?
Yes.
Is that, and how do you do that?
Usually we use eye drops. The first drop we use is usually a once a day at bedtime eye drop. There are also procedures like laser that help to decrease the pressure as well, and they are as effective as eye drops.
And what's a typical age is there an age range for glaucoma, or it can happen at any age?
It can happen at any age, but certainly it's more typical as we age. So the average age for glaucoma would probably be more in the mid-60s or 70s. Again, a history of trauma can put you at a higher risk for glaucoma. Certain medications can put you at a higher risk for glaucoma as well.
Great. Well, let's move on to the cornea and some of the common corneal diseases and things that can occur there and affect your vision. So just review what the cornea is again, and then what some of the common problems are with it.
So the cornea is the clear tissue right in the front of the eye. Okay. Some of the most common things that can affect the cornea are actually dry eye disease. Dry eye disease can cause symptoms like foreign body sensation, blurriness in vision, and just general discomfort. Other things that I treat that can have more surgical implications, there's a condition called keratoconus where the cornea becomes more cone shape. There's a condition called Fuchs dystrophy. Fuchs dystrophy is a condition where the cornea starts to become thickened because it starts gathering fluid. So the cells in the cornea that act like a sump pump in a basement are not working. And this could prove to be an issue after cataract surgery, in which case we can do a procedure called a corneal transplant.
Okay, so you can replace the cornea?
Yes, and actually the cornea is the only real part of the eye that can be transplanted. The sclera as well, but functionally, for vision, the cornea is the only part that can be transplanted.
So there'd have to be a donor, and is there
Absolutely.
same issues with matches, or not such a big issue in the
cornea?
cornea?
So interestingly, because the cornea does not have a blood supply, we do have to be a little bit concerned with rejection, but we don't have to match based on HLA typing. We don't have to match based on blood type. We're able to pretty much use any cornea that comes as long as they fit within certain parameters. We can use that in our patients. They can still have rejection though, and we treat it in the similar way by using a steroid eye drop. Sometimes oral steroids are needed as well.
So do you go to like a corneal bank for that?
Yes, there's an eye bank. Lions Eye Bank is probably the most well-known one.
And then when you surgically insert it, is there sutures, or how do you do that?
So there's the full thickness corneal transplant where you're replacing the entire cornea. So using a special trephine or a blade, we make an incision that goes fully around, and that portion of the cornea is removed. Then we obtain the donor tissue and we place it on, and it's about 16 sutures is the typical sutures that I'll place for a standard full thickness corneal transplant. With Fuchs dystrophy, for instance, in that condition, we're able to replace only a single layer of cells, and one of them is called DSEC, another one is called DMEC, where we are replacing just that single layer of cells, so we're not needing to remove the entire circle of cells. We're able to just make a small incision, remove a sheet of cells, and place the new sheet of cells in the eye. And that tends to recover more quickly.
Wonderful. Before we wrap up, just quickly, is there any new things on the horizon in eye surgery that people can look forward to? Things like transplants or cell injections or anything? What's coming down the pipe?
Sure, there are currently studies going on for replacing parts of the retina and also using stem cells for that. There are enhanced refractive procedures, so certain people who are not candidates for LASIK and PRK, we can use different types of technologies to help improve their vision. As well as the lens implant options for cataract surgery.
Wonderful.
Getting better technology, being able to more mimic what our natural eye was able to do.
Great. Well, thank you for joining us today.
Thank you so much for having me.
You heard Dr. Naadimuthu talk about various eye diseases. Thank you for joining us on You and Your Health. Until next time, I'm your host, Dr. David Bertone.